All right. Good morning, everyone. We're really fortunate to have Dr. Allan Brett join us again, probably for the fifth time here at the University of Colorado. But he's been doing this style of talk for about 30 years, both at Harvard and University of South Carolina. Dr. Brett's going to be giving us the year in review of general medicine. Dr. Brett did college, medical school at Penn, residency at Pitt, and then was at Harvard and the University of South Carolina before coming here to the University of Colorado. Currently, he's at the VA where he both precepts in the resident clinic and teaches medical students. Dr. Brett has been with New England Journal Watch since 1988, was the editor in chief from 94 to 2025, and is still an editor at large there. And I will note that New England Journal Watch was renamed 2 months ago. 2 months ago. Yeah, December 2025 to New England or NEJM clinician, as we'll see on the next slide. If you have questions, excuse me, I should say when you have questions, please put them into the chat as we're going. We'll pause after each topic and questions live in person. Raise your hand and I'll walk over to you with a microphone. And with that, I'll turn it over to Dr. Brett.
Thank you. While I'm thinking of this, the references for each of the topics that I do are on the slides, and they will be sent out to everybody, right? So if you say, gee, I didn't read that, I'd like to, you don't have to scramble to write it down. You'll get the slides and they'll all be there for you. All righty, so thank you. As was just mentioned, those of you who are long-term readers of NEJM Journal Watch, there's been some changes there. It's a long story that I'm not going to get into why the changes and so forth. It's now called NEJM Clinician. In print, it looks pretty much the same as Journal Watch. Online, it's a brand new interface that pulls in some stuff from the New England Journal itself. And you can have a look at that. Unfortunately, the institutional subscriptions model, in other words, if you get into this through the e-library, it actually doesn't look the same as if you pay money yourself. They've curtailed it for some, business reason. So I'll just say that and move on. Okay. Today's topics are, I'm going to do 5 topics today and 5 or a few more even maybe next week, but we'll finish this up next week. Asymptomatic carotid stenosis, long-term reduced dose anticoagulation after venous thromboembolism, some migraine things that I think might be useful to you, a guideline on asymptomatic hematuria, and new indications for semaglutide. In the last couple of years, we never have one of these without a GLP-1 thing. It's like unavoidable, right? Okay, let's plunge into this. The story here starts about 30 years ago when 2 large randomized trials were published, one from North America and one from Europe, comparing endarterectomy to medical management without surgery in patients with asymptomatic carotid stenosis. And in those studies, there was a several percentage point benefit at 5 years. In other words, fewer ipsilateral strokes, but at the expense of an uncomfortably high postoperative stroke rate. And then since then, there have been advances both in interventions and in medical therapy. So it was necessary to repeat the study in more modern times. And that's what we're going to talk about today. CREST-2 is a landmark trial, one of these long-awaited trials that people talk about. Began in 2014, slowed down because of COVID and so forth. Finally was published after more than a decade, just in November in the New England Journal of Medicine. It's a North American study. It involved patients with asymptomatic stenosis greater than or equal to 70%. And it had 2 parallel arms, endarterectomy versus endarterectomy with medical management versus medical management alone, and then the same with stenting versus medical management alone. So there wasn't a 3-way comparison, 2 parallel trials. Endarterectomy wasn't compared to stenting directly, I guess you could say. I should also mention that in the medical therapy, unlike the old trials, the patients in the medical therapy arm were managed at the research centers, not by usual care, and they had targets for cholesterol and blood pressure management. So it was maybe more rigorous medical management that you would see if people were left to their own devices. The outcome is a composite outcome. It's always interesting to look at what randomized trials select. This is 4-year follow-up, and there are two components to this composite outcome: any stroke or death during the first 6 weeks, and that's basically to capture the bad things that happen at the time of the procedure, postoperative strokes in particular, right? And then why they picked 6 weeks, I don't know. But then after 6 weeks, the other component of that endpoint is a ipsilateral ischemic strokes. In other words, figuring 6 weeks are gone, anything that's going to happen to you from the procedure is probably gone. And now let's just look at the actual ipsilateral carotid to see whether it prevented strokes. And what you see there is in the endarterectomy arm, there was no significant difference. It was a small 1.5 percentage point difference that did not reach statistical significance. And they didn't really go into more detailed analysis of that one. I mean, you can get it online, but in essence, they say that wasn't significant. Let's move on and see what happened in the stenting arm. And in the stenting arm, as you can see, it's about a 3 percentage point difference, 2.8 versus 6%. And that did sneak under the 0.05 level. So in that first 6 weeks, let's now look at this first 6-week endpoint. And again, it's very interesting. You won't see these numbers in the main article. You'd have to go to the supplemental appendix to see these. There were 8 events with stenting out of 600 and change patients. 1 death, 5 non-disabling strokes, and 2 disabling strokes. And that comes out to a little more than 1% of the 600 patients there. At 4 years now, when you look at the whole composite endpoint and you actually sort of dissect down the 3 percentage point difference, which would be like a number needed to treat of 30 some, right, is entirely accounted for by 20 excess non-disabling strokes in the medical group. Death and disabling strokes, there was no difference in the two groups. Now, we don't want patients to get a non-disabling stroke, but it's still worth parsing it out that way. And that accounted for that final difference at 4 years. And then I wrote here, well, how would you discuss this with a patient? You could say for every 100 patients, stenting prevented 3 non-disabling strokes and at the expense of 1 procedural stroke. And maybe the second bullet is maybe almost the important one here. The proceduralist who did the procedures in this study had to demonstrate a large volume previous experience with low complication rates. And assuming that information was honestly submitted, the question here is, how would this play out sort of to all comers in your average medical community? And we don't know that. I mean, even in your medical, if you want to know this proceduralist, what's their rate of postoperative strokes, it would be hard to find out, right? And then the other question that comes up, this is asymptomatic carotid stenosis. So by definition, they never had a neurologic ipsilateral event. How are they even identified? If you look at the protocol online, it says, well, we posted media publicity in the communities, and we sort of canvassed practices at our medical centers to identify patients for us. And, you know, what does that actually mean? In real world practice, I'm sure if we polled everybody in this room and you've seen patients like this, how they got identified would be a little different from person to person. Some practices, cardiology and vascular surgery practices, I've had patients where the patient's there because their coronary disease or their leg peripheral vascular disease, and while we're doing ultrasound, let's put that thing on your carotid and see how your carotids look. That's one way. Also, probably inappropriate carotid imaging in somebody who has a syncopal episode that's not plausibly anything to do with carotid stenosis. Let's do the workup and so forth. The U.S. Preventive Services Task Force recommended against screening, by the way, in 2021. And back to the previous bullet, my point was that depending on how a patient was discovered to have asymptomatic carotid stenosis, the way these outcomes play out might be different in some of these subgroups. We just don't know. Does anybody here ever have a patient come in with a report from Lifeline Screening? It's a national company, and they send vans out to like church parking lots and shopping centers and so forth, and you can sign up online. A few days ago, I looked. If in the next 30 days in Greater Denver, you could get them to do one of their screening packages at various places in Denver and its surroundings. And they'll do carotids and ABIs and AAA screening and so forth for like $150 or something like that. And when I went online to see this, the first patient testimonial that was right there on the homepage happened to be, everybody was telling me to check my carotid artery and see if there were any blockages. I had it checked and there were slight blockages from what they could see in their pictures. It's not a very inspiring way, as opposed to I had a 90%, and so forth. But anyway, so that's out there too. And I'd have patients who have come in with the sheets from these things, say, what do I do now? So when I wrote the summary for this for Journal Watch, and I was kind of nervous about there was something about it, about, how would this translate to the community and so forth, where I didn't want to say, okay, P.02, everybody who's identified here should have the procedure. It seems a little more complicated than that. So I then took a deep breath and read the editorial. Now, who writes editorials is a good question. The two editorialists here were not from North America. One was from the UK and one was from Sweden. They were neurologists. They were not interventionalists per se. And it was a very thoughtful one. They talked about number needed to treat. They talked about potential for perioperative adverse events, in doctors generally around the world and so forth. And the fact that the difference was entirely attributable to non-disabling strokes. They were ranked by that Rankin scale that's used for disability after stroke. And this is a direct quote, what they conclude. We consider it reasonable to advise patients with asymptomatic carotid stenosis to start intensive medical therapy immediately and delay revascularization until such time as symptoms develop, which will occur in only a small proportion of patients. So it's kind of interesting. I was on that page when I was writing my Journal Watch summary. And I sent my summary before we published it. One of a Journal Watch neurology editors was an investigator in CREST 2. And I said, what do you think, And he said, I pretty much agree with you. He basically said, I wouldn't change anything. So that's kind of what I concluded in my summary of the study. And I'll just end by saying it'll be really interesting over the next year or two to see how people use this study in their practices, particularly the people that, do endarterectomies and or stenting. So I'm going to stop there and see if anybody has any comments, questions. I always say here that, I'm not, this is a wide swath of topics. I'm not the world's expert in any of them. So if somebody has something to add that I missed or whatever, please.
So I'm curious, this started in 2014, and my sense is that since 2014, medical therapy targets have changed. So, our blood pressure targets are lower. I think the trend is towards lower LDL targets as well. Do you have any sense of what the endpoints they were aiming for in
Yeah,
medical
it's
therapy?
all listed in the protocol online, and I think it was like an LDL less than 70, and to try to get the systolic blood pressure under 130. I don't think it was 120, but it was like 130. And they even mentioned that, in the later years, we used not only statins, but other, more some of the later developed cholesterol lowering drugs if needed to get it under. Exactly, how compliant people were. Did they pay for these drugs? I wasn't sure about that. Yeah.
Do you recall if they did any subgroup analyses based on how severe the asymptomatic stenosis was? I know the inclusion criteria was 70% or greater, but I'm thinking, is there a difference for patients if their asymptomatic stenosis was 70% versus 99%?
Yeah, I don't think they actually did that. They didn't subdivide that. And if you think about it, if 3% of people or, to 6% at endpoints, you would start to get such tiny numbers if they then start divided up, 70 to 80 and there's a certain amount of subjectivity even on where and how you cut it off. I think most of them started with ultrasound and then people had to have angiography and other studies to do it. So I don't know the answer to that. And yeah.
And I ask that because you highlighted at the beginning, there's some of those RCTs from decades ago that have guided a lot of management. And so psychologically for me, I just get nervous about those patients with more severe stenosis. And
Yeah.
I feel like that can be, for the asymptomatic
Well,
patients, more of a
right.
gray zone.
I hope I'm not, going beyond what I really truly know here, but there's all this other research that it may, the degree, old research suggested that that was some cutoff where there seemed to be some inflection point where intervention might be beneficial. But more modern stuff talks about the characteristics of the plaque and how much ulceration, is it fibrotic and stuff, that actually may, predict what's going to happen better than the degree of stenosis. So the degree of stenosis sort of works in a crude way, but I've seen people who, in my career who had less than 50% stenosis, but an ugly ulcerated plaque that, a thrombus presumably flicked off from and caused a stroke. So one more, is there any other online questions? Okay. Next. Long-term anticoagulation after venous thromboembolism. In my precepting at the VA, we've already used these data on several patients. So the story here is in some patients with VTE at high risk for recurrence, indefinite anticoagulation is recommended to reduce the incidence of recurrence, especially we're usually talking about unprovoked VTE. And of course, the trade-off is as you keep somebody on a blood thinner for years, you have this incremental risk of bleeding that continues. So the question is low-dose anticoagulation as good as standard dose? Can we get the same benefit with less risk by using lower doses? And this was, people were beginning to do this before these 3 trials, but the guidelines were soft. And these are 3 really good trials, all of which were published in 2025. So the first is a study from France, big study, 2,800 patients with acute VTE at high risk for recurrence, which there was a few things, there were a few other categories of inclusion, but it was basically unprovoked venous thromboembolism, either PE or proximal DVT or both. And active cancer was not in this study. That was an exclusion. That's going to be the next one I'm going to show you. Patients had received between 6 and 24 months of full dose, either apixaban or rivaroxaban in their regular practices, and then were recruited into the study. And at the time of the study then, they were randomized to continue full dose or go on with half dose, which would be 2.5 twice a day of apixaban or rivaroxaban 10 once a day. That was at the discretion of the doctors who were taking care of them before it all started. Which drug? I guess those are also the 2 most common ones in France. The estimated 5-year recurrence rate was almost exactly the same, around 2% in both groups. Major bleeding, as expected, there was only a 2 percentage point difference, but that was statistically significant, 2 versus 4%. Major bleeding is one that lands you in the hospital, requires transfusions or a bleed into a critical organ. Clinically relevant non-major bleeding is defined as everything else beyond those big time things that make the patient seek medical attention. So it's often vaginal bleeding, hematuria, things like that. And that's also lower in the half dose group. And the outcomes didn't matter which of the 2 drugs the patient was on, the percentage outcomes looked roughly the same. The second one is cancer, international study, 1,800 patients with active cancer and VTE. 3/4 of those patients had pulmonary embolism with or without an identified leg clot, and then 1/4 of them had only proximal leg. These patients had received a minimum of 6 months of full dose, and then at the point of entry into the study, they were randomized to either 2.5 twice a day or 5 twice a day of apixaban. The 12-month recurrence rate here was almost the same. It was actually a wee bit lower in the reduced dose group. That's not statistically significant, but at least it goes in the right direction, is the way I look at it. And then major clinically relevant non-major bleeding, here they're lumped together and it was lower in the low dose group. If you looked at them separately, it was roughly proportionally the same differences. All-cause mortality was a secondary endpoint that was also lower in the low dose group for reasons that are unclear, but again, it's nice that it went in that direction. The third study actually is very interesting because it actually sort of encompasses something we see all the time, but nobody had really identified as a discrete group. And it's people, and the authors here named this provoked VTE with, quote, enduring risk factors. That's the word they used in the New England Journal study. This study had 600 patients. It was actually all done in Boston and included patients who had a provoked VTE by one of your traditional provoking factors, surgery, trauma, or acute illness, plus in the background, an epidemiologic factor that we know from large studies increases your risk of having venous thrombosis somewhat over the average in the population. And, and these include obesity, chronic lung or cardiovascular disease, and chronic inflammatory disorder. So patients could get into the study, they had a provoked thromboembolism and one of these background factors that modestly increase your risk in general of venous thrombosis. Cancer was not in this study either. And in this one, patients got standard dose treatment for 3 months, and then they were randomized to low dose apixaban or placebo. This was not a comparison between high dose and low dose. At 12 months, the recurrence rate, it's pretty amazing, 1.3% versus 10%. That 10% here in this group is what old studies showed in people with unprovoked VTE who were not treated after after a short period of time. So this constellation of provoked VTE with these enduring risk factors sort of looks like unprovoked VTE. And clinically relevant non-major bleeding was a bit higher in the, even though there was low dose, there was still more bleeding. There was hardly any major bleeding, life-threatening bleeding in this particular study. So basically, I think this is the last study here. Yeah. So basically here in conclusion, the first two studies, unprovoked VTE and cancer-associated VTE, I think now we can comfortably give those patients reduced dose anticoagulation after the initial period of full dose. In that third study, the provoked plus above average background risk, we should probably consider longer than a few months anticoagulation, but we can do that with low dose, half dose. And then what happens after 12 months? That was just a 12-month study. I just sort of wrote here, probably need to individualize that according to the patient's risk for bleeding. And these background risk factors may get worse or they may go away, depending on what's going on with the patient. So that's going to just have to be trial and error or individualized on a case-by-case basis. And I think these studies will sort of almost certainly go into the next edition of the ACCP anticoagulation guidelines and so forth. Stop.
A question we have in the chat, not for the third study, but for the first two studies, do you know if obesity was an exclusion criteria?
I think that, well, the second one was cancer. So that was what you had to have to get into that one. And in the first one, I'm pretty sure it was not. These were, I forget, it was like 90+% of these were classified as having unprovoked. And there were a few other things for a very few number of patients that they counted as another way you could get into the study. But I think those other things, obesity and history of cardiovascular and pulmonary disease, it was in that third set. I don't think those were ways that you could be qualified for that first study.
For the third study, I'm more familiar with that one. It was about 50%, half the patients.
I'm sorry?
For that third study for the provoked DVT with enduring risk factor, for about half the patients, what their enduring risk factor was obesity.
Mhm.
And I say that because how many of our patients that we care for that have that comorbidity, that third trial really has potential to change what we do for a dramatic number of patients.
Yeah, I mean, just think about, a sort of a non-specific general cohort of patients. A lot of them are going to have obesity or cardiovascular disease or pulmonary disease. Exactly. Keep going. All right. We're on time. I think hopefully we'll finish a couple minutes early, and then if somebody thinks of a question from one of these earlier ones at the end, we can still do that. Let's see how the time goes. All right, so now I'm going to switch to, I'm going to present 3 studies related to migraine, none of which by themselves probably would have ranked, for this end of year thing, but together, these are things that are common and that, interestingly, I've actually used in my precepting already, each of the 3 that I'm going to show you. So, if you're familiar with migraine guidelines, the neurology literature has a number of organizations that do it. ARBs and ACE inhibitors actually mentioned in a lot of those. And you don't really see people use them, I think, in general practice for migraine prevention. But they're kind of second tier and they're based on very small studies. Exactly how somebody decided to look at those drugs to begin with, I'm not sure, but there are angiotensin receptors in the brain, so there's a brain connection, I guess, if you will. So this is a study, for some reason, candesartan is the one that's been looked at in tiny studies, and this is a large study of candesartan in Lancet Neurology, 460 adults. 2 to 8 days monthly, migraine days, they call them, and a mean of 6 to be in this study. And they used the 2 lowest doses of candesartan, 8 and 16 milligrams, or placebo. They excluded patients taking antihypertensive drugs, not because they are more or less likely to respond, their migraines to respond to this, but by inference, I think they didn't want to start making people hypotensive with multiple drugs. And what they found was that there were 2 fewer migraine days per month with either dose versus 1 with placebo. So it took the mean from 6 to 5 with placebo and 6 to 4 with candesartan. So if you were like me, you're thinking, well, that's nice. That was statistically significant. That's not a huge difference. Now, it turns out that most migraine trials, this might even be a requirement by the FDA, I'm not sure, show their endpoints are often a 50% or more reduction in migraine days per month. So they also looked at it in that way here, and it was 50% versus 28%. So this is a way, when you see a difference in means that's sort of modest, to see what proportion of patients had a more robust response. Now you're looking at the 50 versus 30 and you say, oh, that's not bad, right? But still number needed to treat of 5 to benefit 1 by that endpoint, 20 percentage point difference. And it's interesting, I co-wrote this one in Journal Watch with a migraine neurologist. And she said, you know something? Look at the CGRP studies, the newer GAPANT studies that cost thousands of dollars. Look at their 50% versus placebo. 50% reduction. It's about the same. And so I looked at a couple of the pivotal studies, about a 20 percentage point difference using that endpoint. So this doesn't look bad compared to what's out there anyway. It kind of shows you that, one size doesn't fit all. It's a kind of a trial and error, which we sort of know from trying to, get these things under control with some patients. Dizziness was more common with candesartan. It was 30 versus 13% there. But they say that only a couple of patients withdrew because of this side effect. I don't quite know then, how bad that was. And they really didn't show the blood pressure responses. And then my last note is, in researching this, I found that actually candesartan was compared to propranolol in an old trial like 20 years ago. It was like 60 patients, only 30 in each group. And despite the small numbers, the outcomes were pretty similar to this. They were equal. So to me, I think you can dispute me. I think most people in general medicine often start with beta blockers and not the CNS active antidepressants and anti-seizure drugs for prophylaxis. And I think maybe you have 2 options now. If you don't think the patient would be a good candidate for a beta blocker, you might use the low dose of the ARB here. And I don't know, maybe give them a blood pressure home monitor if they're normotensive to make sure that the blood pressure doesn't drop significantly. So that's the first one here. And just a divergence. So right when this came out, I was precepting, and one of the residents had a patient who said, I think it's time for me to have prophylaxis. I'm having too many migraines. It was a patient with actually mild hypertension who didn't like to take medicine and had resisted treatment. And the chart showed sort of averages of 150s over 90s for a couple of years. So it was like we killed two birds with one stone. I don't know what the outcome was in that case, though. The ACP published guidelines on migraine this past year, and they're shorter than the neurology organizations ones. And I just want to make one point out of them. This was in the annals. The prevention one looks just about the same as anything you'd read on Up to Date or whatever. I just go to the treatment one, however. They made a big point of this, and I think this is a useful point. They made a big deal out of the fact that studies show that combined treatment with a triptan plus, this is treating an acute migraine now, and an NSAID or acetaminophen are more effective than either one alone. So often for people, who are in the early stages of our treatment, we'll use a triptan or we might use an NSAID. I don't see people using acetaminophen alone very often, but there is studies saying it's better than placebo. And they basically cite some literature saying that the two of them, there's studies showing that they work better than either one alone. And since, it's pretty easy to combine them. The biggest study was a 2007 study, so it's almost 20 years ago, in 3,000 patients. It was marketed by the sumatriptan company. They were randomized to sumatriptan, naproxen, monotherapies, both of them, both or placebo, and combined treatment was statistically significantly better than either monotherapy or placebo. So I think that, we could have a lower threshold for, say, combining these in a patient for acute treatment. And then the third thing has to do with migraine prodromes. And I kind of knew about this, but not much about it. And it turns out that many patients have what is labeled as a prodrome, many hours or even a day before the headache, some non-specific symptoms. For that patient, they know something is going to happen that day. And this is distinct from focal neurosymptoms that we call an aura, which are minutes to an hour before the headache. And this was a study of 900 patients. They were actually part of one of those GAPANT studies, but they did this sub-study of 900 patients with frequent migraines, a history of a prodrome. The patient said, I consistently get a prodrome 1 to 6 hours before the headache. And they followed these patients for a couple of months prospectively with a diary. And then they analyzed the diaries. You can see the most common symptoms. They're kind of all over the map there, but light sensitivity, fatigue, neck pain, sound sensitivity, difficulty thinking. I talked to one patient after reading this, and she said, for a couple hours before I know it's happening, I just can't concentrate. Something is going on. And then a few others there. And the study, they analyzed the clusters of studies, and they found that most patients had 2 or 3 of these, and the pattern seemed to be consistent per patient. In the study that generated these data, it was a uprogapant. I'm not sure which brand that is. Treatment during the prodrome was significantly more effective than waiting later. And then my informal discussions with some neurologists have started to do this more, no matter what the drug, no matter what the acute drug that they're using is. So we don't have good data on it, but it seems that at least among neurologists, asking about the prodrome and starting treatment there might be worthwhile. And okay, so those are things that I think are useful in primary care practice. All right. Not too much controversy there, I guess. Let's keep going then. So this comes up very frequently in primary care. And looking at this guideline, I thought, something, it seems all over the map what we do with these patients. And this seemed to be a reasonably well done It's a very readable guideline, actually, from the American Urologic Association. So we summarized it, and I thought this is a good bread and butter topic. The AUA defines microscopic hematuria as 3 or more red cells per high-powered field in a person without a history of gross hematuria. And if you're thinking, where'd they get that? I tried to find it, and I'm not sure where they picked, if there's really any documented inflection point above 3 where, it's much more likely to predict malignancy and so forth. That's what they use. And that's what some of the studies use. This also, very importantly, applies only to isolated microscopic hematuria after an H&P, and a full urinalysis excludes other explanations, such as if a person has glomerular disease, they might have high-grade proteinuria. If they have a lot of white cells, it might be infection causing the microscopic hematuria, contamination from vaginal bleeding, and so forth. So you gotta exclude all those things. And anyway, the study basically starts, it tries to risk stratify patients into groups, and then based on which group you end up with, how extensive the workup should be. That's where we're headed here. And it's really focused on the risk of cancer, bladder and kidney cancer. And the guidelines based on a lot of observational studies, which are all flawed in some way, and that's what we have. There are no randomized trials of different approaches here to inform this. So it's a best shot at taking thousands of data points and just trying to make some sense out of them. So they come up with 3, they sort of somewhat arbitrarily come up with 3 groups: low negligible risk for a GU cancer, intermediate, and high. And in parentheses, the reason that there's ranges there, because this is drawn from a whole bunch of observational studies and they had to pick something, so they basically ended up with those data, which is not exactly clean. And then there's a very complicated, almost full-page table there, and I synthesized it into something that's easy to show here. The low to negligible, that's people who have close to a 0 risk of cancer. You have to have all these criteria to be in that group. 3 to 10 red cells, lower age and lower smoking history, and no additional risk factors. To get into the intermediate group, 1 or more of those have to change. More red cells, older age, more smoking history, and then, or a history of exposure to, say, industrial agents that have been linked to bladder cancer, a family history of kidney cancer. There's some genetic things that go there. And then yet further extremes in those categories in the high-risk group. And so most patients can be categorized in one of those 3. And then the question is what you do with it. For the low negligible risk, they recommend repeating it in 6 months. If there's persistent low-level red cells per high-powered field, they retreat to the shared decision-making on further evaluation because, basically they say we don't have a lot of good data that somebody with 3 to 10 red cells and none of those other risk factors, it's such a tiny risk in the foreseeable future of cancer that it's hard to say do X on everybody. So it's shared decision making. If the person on repeat is now at a higher level of hematuria or something else, reclassify the patient. For intermediate risk, they recommend cystoscopy and renal ultrasound. This is a kind of a shift where their analysis of data from imaging suggests that in this category, renal ultrasound will suffice just as good as a CT scan or MRI for upper tract imaging, and then high risk cystoscopy with upper tract imaging by CT or MRI. When I said that it's a very readable guideline, and what's nice to me is that they kind of think of scenarios that the average doctor might encounter, which the second and third bullets we'll get to. The first one, we won't encounter that much, but they go into more detail about family history of renal cell carcinoma, the various genetic syndromes that are associated with this. And if somebody has one of those, upper tract imaging with CT or MRI is suggested, regardless of how many red cells you have. But then they go into intermediate risk patients, and they recognize a lot of patients say, I don't want to have cystoscopy. And basically, they do address the sort of the strategy of using urine cytology, or there's now a bunch of urine-based tumor markers that commercial labs run. And they go through the sensitivity and specificity, and they're not perfect. But so basically they say we would prefer to get the patient to have cystoscopy, but it would be acceptable to use one of those second line things in a patient who says, I just don't want that. And then finally, if the initial evaluation is negative, in other words, you do the whole thing, no matter which of those three categories you're in, and then should you repeat the should you keep checking? Should you repeat the whole evaluation in somebody that's in the third category, the high risk one, but the imaging and the cystoscopy are negative, or you're not sure where the red cells are coming from? And basically, they honestly say we just have no data there to and just sort of decide on an individual basis with the patient. So some of that's frustrating, but it's real life, and I thought this was a reasonable way to guide us. So I think that's the last one for that one. Yeah.
I don't have a question yet. It's really just more of a comment, following up on the last thing you said there, Dr. Brett, which is I find when we do these evaluations and they come up negative, that can be really frustrating because for all this, we lack good, strong prospective evidence, but this is the best that we can do here. But then someone's intermediate, high risk, evaluation's negative. Do we just forget about it? Do we repeat it in 3 years and 5 years or 10 years? No one really knows. And I feel like for us as clinicians and then for the patients too, it's just this sort of black box.
I actually didn't think of this until right now. I should have. The first thing, the asymptomatic carcinosis. We're not supposed to screen people for asymptomatic microscopic hematuria, but given how often UAs are done for all kinds of reasons, we find it, right? So maybe it depends on how you found it and what was the reason the urinalysis was done to begin with to inform what to do next. I mean, I'm just kind of making this up as I go along, but and it's always interesting where do the red cells come from? I mean, people have AVMs in the urinary tract, and that's thought to be a source of ongoing microscopic hematuria, just as you get in the GI tract. That's one of them. Some of it may be glomerular bleeding, in somebody who doesn't have high-grade proteinuria, for low-grade, some sort of glomerulopathy, whatever. Mark?
Well, apropos of one of the earlier topics, they also don't incorporate anticoagulation as how does that modify their guideline?
I think, actually we covered some observational study this year. I can't quote all the numbers at all, about how that basically is sort of what we were talked. If somebody has hematuria on anticoagulation, don't just say, oh, it's the anticoagulant, stop there. You're supposed to do the same workup. So, and I think they just mentioned that in the guideline. Yeah, you're supposed. Yeah. I mean, could you make up in somebody with a low intermediate group and just has 3 or 4 or 5 red cells and none of those other risk factors, it happens to be an anticoagulant, and maybe in that case tip you to not going further? I mean, you could make up stuff here that might make sense.
Yeah, is there any data in men whether split urine samples are helpful in localizing the source? Yeah, is there any data in males? Do split urines, looking at initial urine versus later on, help localize? Yeah, probably not.
Yeah, the question is, midstream, early stream, which is supposed to localize, urethral bleeding versus kidney bleeding, all that stuff. for microscopic hematuria, I would guess there's no data to do that. I mean, whether it could help, I don't know, but does anybody know the answer to that? Terminal hematuria versus early hematuria. I would bet that there's nothing in the literature to inform that question for microscopic hematuria. Great question. All right, right on time here. Okay, the obligatory GLP-1 segment now. So we're going to talk about 2 new indications for semaglutide here. We'll start with metabolic dysfunction associated steatohepatitis, or MASH. And of course, we know that this is generally, we start off managing this with lifestyle intervention and treatment of the associated conditions that the particular patient might have, which is often diabetes and or obesity and or hyperlipidemia. Now, the drugs that have traditionally been used to treat those conditions have not been FDA approved to actually treat NASH, or now MASH, and the studies are fairly modest. The first drug approved specifically to treat this is a drug called, I don't know how to pronounce it, resmetirom. It was FDA approved in 2024, and its mechanism is interesting. There are thyroid hormone receptors in the liver, and it's an agonist of those receptors, and it's been shown that improves liver histology in people with MASLD or MASH. The out-of-pocket cost of that when it came out was huge, and I looked like a month ago, and it's still ridiculous. And if somebody at the end has seen this used, I'd like to know about it. I don't think it's not on the VA formulary, and I haven't precepted any patients that were on it. So my guess is it's not being widely used yet. Then in 2025, the FDA approved injected semaglutide to treat MASH with stage 2 or 3 fibrosis, and it was based on a randomized trial published in the New England Journal right before the FDA approved it for this indication. So the patients in this study had a mean BMI of 35, and over half had type 2 diabetes. And really, if you kind of look at the data here, almost all the patients in this study had one or the other or both, which is going to create a problem in how to use the drug at the end that I'll bring up. Patients were biopsied, so the stage 2 and 3 fibrosis was biopsy proven. It was not an indirect study. And they were randomized to the gradual titration to 2.4 milligrams of subcutaneous semaglutide or placebo. And then repeat biopsies were done at 72 weeks. And these studies and that 2024 with that other drug, this has become, I guess, a conventional way to analyze these biopsies. Steatohepatitis resolution without worse fibrosis. The inflammation is gone and fibrosis is at least no worse. And you can see about a 30 percentage point difference there. Reduction, the sort of the converse of this, reduction in fibrosis without worsened steatohepatitis. Those numbers are smaller, but the difference did reach statistical significance here as well. Now, this was a first look at the data. This trial is going on for almost 5 years, will be going on for almost 5 years, because really the biopsy is sort of like a surrogate outcome. And in 5 years, they're going to look at actual liver outcomes, cirrhosis and complications of liver disease, and see what that shows. So now this drug can be prescribed specifically for the MASH indication. And of course, we'll take into consideration, in any case, costs and side effects and so forth. And then one thing that I thought of, and others have too, is very few patients in this study were not obese or overweight, and without diabetes, let's say. So, and those patients, we occasionally end up with this diagnosis as well. And should the drug be used in those kinds of patients? Will it be effective in those patients in the same way, at least histologically, it seems to be here? That's unclear. And then the second new indication is oral semaglutide for weight reduction. The oral one, which went by the name of, or does go by the name Rybelsus, was approved in 2019 solely for diabetes control. And then in October of this past year, there was a big study published in the New England Journal of the oral drug's use to reduce the risk of major cardiovascular events in adults with type 2 diabetes at high risk. It's a large study of like 10,000 patients that the drug company funded. And it showed something like a 1 or 2 percentage point lower MI rate at I forget how many years, which was statistically significant with 10,000 patients. So that was added for Rybelsus, an indication. Now, just not only diabetes, but reduce cardiovascular risk. And then in December, just 2 months ago, the drug was approved for adults with obesity or overweight plus at least one weight-related comorbidity. And now the games that they're playing with the names come into play. As you'll see in a moment, I'm going to show you the study that got this approved. The 25 milligram, the higher dose that this study looked, is now oral Wegovy as opposed to Rybelsus. So you got Ozempic and you got Rybelsus and you got the oral Wegovy and the subcutaneous Wegovy. I never mention brand names except to help confusion in these presentations. It's important for people to know what's going on. So this was a placebo-controlled trial that got it FDA approved. It only had 300 patients, but that's all you needed to get a highly statistically significant result. High BMI, mean weight of 106 kilograms. And this study, importantly, did not have patients with diabetes. I'm not sure if they're doing a parallel one with patients with diabetes here. And it was titrated over 3 months to 25 milligrams of new oral Wegovy. The previous highest dose of oral Rybelsus was 14 milligrams, okay? But it's a 3-month titration. And the 64 weeks was the outcome, 14%. This is the mean weight reduction was 14% of body weight with the drug and 2% with placebo. And it turns out that if you go back and look at the studies that got injected semaglutide, FDA approved for people without diabetes, it's almost the same as that. One of the studies was 15 versus 3%. So it's about a 12 percentage point difference. This is the mean, right? Some people lose much more, some people lose less. What's the price? I just saw fleeting. I had turned the TV on to watch some sports event over the weekend. I saw the last 10 seconds of now oral Wegovy. So we're going to see a blitz coming up. And if you go on the Novo Nordisk website, the current monthly quoted price is $149 to $199 for the lower doses and $299 a month, for the higher doses. I don't know if this is a loss leader and it's going to go up after a few months. There's some asterisks qualifying it on their webpage. But anyway, that's what they're quoting right now. And I think it'll be really interesting to see what patients' preferences are, both patients who are starting anew on these drugs and somebody who's been on the injectable one. I imagine some people say, will perceive the injection to be more powerful and say, I'd just rather stay on that. And other people might say, I'd rather take a pill, every day. We'll see about that. And the cost actually is going to be the out-of-pocket cost. And then this is my last slide. It turns out we're not done yet. This is going to go on and on, new drug development here. There are 3 drugs that are at the FDA now where the pundits are forecasting that all 3 of these are going to be approved in 2026 based on the data. All 3 of these I'm going to show you briefly were 70-some-week studies in patients with obesity but not diabetes. So we're talking about just treating obesity. One is a 7.2 milligram dose of injected semaglutide. And it was compared in a large randomized trial that was published in Lancet Diabetes to 2.4, the current one, and placebo. And for the higher dose, it was 19% weight loss, as opposed to the lower dose, which was like 14 or 15%. So you get somewhat more mean result here, the means. The second one is a combination injection with semaglutide 2.4 plus a drug that's called cagrilintide. This is a synthetic molecule of amylin, which is a hormone that's secreted with insulin from the pancreas and has some similar effects on the various metabolic things that regulate weight. And in this combined shot, 20% weight loss versus 3% with placebo. And then the third one, and this is being developed by Lilly, the tirzepatide company. There's a big, battle for dollars here. An oral small molecule GLP-1 agonist called orforglipron. So the GLP-1 drugs that we know of are peptide, large molecules. This is a much smaller molecule. It's a non-peptide that is nevertheless, that has been developed to be an agonist of that receptor. And in the study that was published in the New England Journal for this one, 7 to 11% weight loss. They looked at different dosing here for this drug versus 2% with placebo. So it's not quite the 14, 15, 19% percentage, but and the article, this is a company funded study, basically said easier to produce, less costly to produce, more reliably absorbed than the large molecule glutide drugs. And that's probably going to have a market niche if it gets approved. So, all right, 8:57. Have a couple minutes here if we're going
to. What were the criteria for a MASH diagnosis? Do you know was it the imaging and LFTs, or what were the?
The criteria were biopsy, but the question is how the patients got to biopsy maybe. And I really don't know, but I imagine it was like what we see in practice. Somebody has, mild ALT, AST abnormalities. They have the risk factors, and then we start doing, the non-invasive studies and so forth. And then I don't know what percentage of those and that had biopsies for the study had stage 2 or 3 fibrosis as opposed to no fibrosis or even no MASH. I don't know the answer to that. They had to get there somehow, I assume by non-invasive clinical impression though. Yeah. So that's a really good question. I asked our liver hepatology consultant, and I've read some stuff written, and it seems to them that if your insurance company requires a reason to do it, that the direction is heading that towards there will be acceptance of non-invasive. They're not expecting everybody to have a biopsy. There's going to be acceptance of it. And you're starting to see studies, and I can't quote the numbers now, of trying to refine with combinations of elastography and this and that, some of those other things to refine to get those intermediate ones, that's 2 and 3 fibrosis, as opposed to cirrhosis or no fibrosis. One more question.
Yeah, out of interest, do they have any explanation why 34% of the placebo group had resolution of their steatohepatitis?
That's a great question. A large proportion, a third of those patients had improvement by that first criterion, right? 63 versus 34%. So what is that? Is it sampling and the biopsy? Is it the fact that, these patients were in a study and, doctors paid attention to them and they got off-label treatments of things, their lipids were better managed, their diabetes might have been better managed, they might have lost weight. So that I suspect it's a combination of medical treatment and that was other than the injectable semaglutide, and maybe there's a touch of, sampling. You're getting a small core of tissue in a big organ there. I don't know if there are any studies of reproducibility. If you stick the liver in 5 places, how close the biopsies are, but okay.
Well, Dr. Brett, thank you for part 1. We're really excited and looking forward to part 2 of the review of 2025 next week. Thank you.
9 o'clock exactly.